variations in blood pressure. We'll start out this chapter talking about normal methods of blood pressure regulation and then get into those alterations or disease processes later on. So some of the determinants of systemic blood pressure would be things like cardiac output. Remember, cardiac output is equal to stroke volume times heart rate. Stroke volume is the amount of blood that is ejected from each ventricle in every heartbeat. Heart rate is beats per minute, so we can reduce this into cardiac output and define cardiac output as being the amount of blood that's ejected from your heart every minute. Now, it turns out that cardiac output is proportional to blood pressure. In fact, our equation for blood pressure is cardiac output times total systemic vascular resistance. Remember, resistance is determined by three different factors. We have vessel diameter, which relates to resistance. We have vessel length, which relates to resistance, as well as the viscosity of blood. So any of those three factors would affect the systemic vascular resistance. And if we know that resistance and multiply it times cardiac output, that's actually what gives us our blood pressure value here. Now, systemic vascular resistance, or SVR, is determined by the radius of arteries or veins, but in terms of measuring blood pressure, we'll typically measure that at the arterial end. Now, so we can also talk about this as being the diameter of the blood vessel, or the degree of vessel compliance and its stretchability. Now, what this slide is showing are the factors that can help regulate blood pressure in your body. So when we talk about cardiac output, well, that's the equation for cardiac output is stroke volume times heart rate. Well, we can change our heart rate and stroke volume through a variety of mechanisms. Now, we know that the heart receives sympathetic nervous system stimulation through sympathetic nerves as well as sympathetic hormones. The receptors of the sympathetic nervous system of the heart are the beta-1 receptors. So if we stimulate these beta-1 receptors, we can increase our heart rate. We can also decrease heart rate through vagal nerve stimulation. So the vagus nerve is what brings in parasympathetic nervous system input to the heart, and this is going to help slow the heart rate down. So you can either speed up the heart by activating beta-1 receptors associated with your sympathetic nervous system, or slow down the heart by activating vagus nerves, which will have a sort of inhibitory effect on heart rate. Now, with respect to stroke volume, that's also regulated by the sympathetic nervous system. And it turns out another effect of these beta-1 receptors in the heart is increasing the contractility of heart muscle, which is going to increase stroke volume. So if you make heart muscle contract more strongly, you're going to be able to eject more blood from the heart. Also, the volume of blood that enters the heart can affect stroke volume. So we know that preload, which is the amount of blood that fills each ventricle before the heart contracts, is also proportional to stroke volume. So if we increase venous return and therefore increase preload, this will increase our stroke volume. And if we increase stroke volume, this will increase cardiac output. And if we increase cardiac output, that will increase blood pressure. Now, we can also change our systemic vascular resistance through a variety of mechanisms. The fastest, though, of which is arterial radius. Now, we know that the radius or diameter of our blood vessels is modifiable because of their tunica media, which is the smooth muscle layer. So depending on the contracted state of that smooth muscle, we can vasoconstrict or vasodilate. Now, vasoconstriction leads to an increase in resistance, and if we increase resistance, we increase blood pressure. If we vasodilate, that decreases resistance and therefore decreases blood pressure. Now, some of the factors that can affect the radius of some of your blood vessels would be things like alpha-1 receptor stimulation. So alpha-1 receptors will lead to vasoconstriction of your arteries, which can increase blood pressure by increasing resistance, and as well as this system called the RAAS, or the renin-angiotensin-aldosterone system, which is more of a mechanism of long-term blood pressure regulation that involves a variety of organs like your kidneys, your lungs, and blood vessels. Now, there are different ways we can measure blood pressure, and we know that when we refer to someone's blood pressure, we typically refer to two different pressures. We have a systolic and diastolic pressure. going back to our cardiovascular unit in anatomy and physiology, we know that systole is a state of heart muscle contraction, and diastole was a state of heart muscle relaxation. So if we're referring to the systolic blood pressure, this is going to be the amount of pressure that's generated while the heart is contracting. And diastolic pressure is the amount of pressure that remains while the heart is in relaxation or diastole. Now, stroke volume is the primary factor influencing systolic pressure, and systemic vascular resistance is the major determinant of our diastolic pressure. Now, we can talk about pulse pressure as being the difference between systolic and diastolic pressure. So if you can subtract systolic pressure minus diastolic pressure, that gives us our pulse pressure, or basically like a pulse. Now, we can also refer to blood pressure in a different way, or mean arterial pressure. Remember, mean is an average, so mean arterial pressure, or MAP, is the calculated average pressure within your circulatory system. Now, if I asked you all to take an average of blood pressure, you would probably be inclined to just add systolic plus diastolic and divide by 2 to get your average. The problem with that calculation, though, is that typically during rest, we spend more time in diastole than systole, so it wouldn't be fair to calculate an average of the two because they're weighted differently. So when we calculate an average of our diastolic and systolic pressures to get our mean arterial pressure, we got to account for the fact that we spend 2 times as much time in diastole than systole. So the equation for mean arterial pressure is 2 times diastolic pressure plus our systolic pressure divided by 3, which gives us our average blood pressure, our mean arterial pressure. And typically when we talk about blood pressure in the body, at least in terms of physiology, we'll just refer to mean arterial pressure, or MAP. Now, there are other ways we can directly measure blood pressure, like intraarterial catheterization. If you want to get the most accurate reading of blood pressure, what you can do then is actually measure it from within the vessel itself. So if you want to measure directly pressure that's being generated by your heart, we can actually place a catheter in the radial artery. And what this does is actually can measure the pulsations of blood pressure and convert this to electrical signals, which can give us these waveforms. Now, this is the most accurate method of measuring blood pressure, and it also gives you a measure of blood pressure in real time. So intraarterial catheterization would be a more useful method of measuring blood pressure during things like surgery. Otherwise, with just a routine checkup of blood pressure, we can actually measure blood pressure, the brachial artery, using a stethoscope and a sphygmomanometer. And this requires careful technique to ensure accuracy. And all this requires, though, is to use your sphygmomanometer, which is basically your blood pressure cuff. And you'd pump this up until the point where you can't hear any whooshing of blood anymore through the stethoscope. Now, what you then would do would be to slowly release pressure from this blood pressure cuff. And as you release that pressure, the first sound you hear, like the first onset of whooshing, would be the systolic pressure. Because at this point, there's enough pressure in blood to overcome the external pressure of the cuff, and that should be your highest blood pressure generated. Therefore, that's the systolic pressure. If you can measure this, what the pressure is generated by the cuff, that should give you a pretty useful indication of your systolic pressure. Now, the diastolic pressure is the disappearance of this whooshing sound, where the blood pressure that remains in the vessel can overcome any sort of external pressure that's being generated, so you don't hear any sounds at all. So once these Korsakoff sounds disappear, then we call that our diastolic pressure. Now, some important sort of confounding variables to consider are things like white coat effect as well as an elderly. Now, the white coat effect you can observe in individuals who get nervous about maybe being in a clinical setting or having their blood pressure being read. So you might have a blood pressure that isn't accurate outside of that particular circumstance. Now, in elderly, we also find that there's this oscillatory gap where there's difficulty hearing sounds of those blood vessels, so you can get more inaccurate readings of blood pressure in this regard. Now, in terms of how our blood pressure is regulated in the short term, This mostly involves your nervous system as well as direct modifications of blood vessel diameter by the blood vessels themselves. Now, when we talk about how our nervous system maintains blood pressure, we refer to this vasomotor center. Now, the vasomotor centers are part of your medulla oblongata, and these vasomotor centers receive input from baroreceptors within the aorta and carotid bodies. Now, information about blood pressure from the aorta and carotid bodies is sent to the vasomotor center, whereby it might use that information to determine any useful adjustments in blood pressure that may or may not be necessary. Now, if it's determined that your blood pressure is too low, what this vasomotor center can do is send input or output through the sympathetic nerves to alpha 1 receptors in smooth muscle of arterioles, and that can cause vasoconstriction of your arterioles, which can increase systemic vascular resistance, which increases blood pressure. We can also activate beta 1 receptors in the heart to increase heart rate, which would increase cardiac output, which would also increase blood pressure. So the vasomotor center can actually really quickly make adjustments in blood pressure in that regard. Now, under more extreme circumstances, chemoreceptors in the medullary vasomotor center can lead to an increase in sympathetic nervous system activity, and this is only going to be activated when blood pressure is extremely low. Otherwise, long-term regulation of systemic blood pressure involves our renin-angiotensin-aldosterone system, or RAAS. Now, the renin-angiotensin-aldosterone system is a system of hormonal communication between your kidneys, lungs, and blood vessels of your body, as well as back to the kidneys and adrenal glands, but we'll come back to that. Now, what happens is that when blood pressure is too low, the kidneys release a hormone called renin. Now, what renin does is it travels through the bloodstream and converts a precursor hormone called angiotensinogen into angiotensin 1. Now, it's important to note that angiotensinogen is made by the liver, and in the presence of renin, renin can convert angiotensinogen into angiotensin 1. Angiotensin 1 will travel throughout the bloodstream, and when it encounters this enzyme ACE, or angiotensin converting enzyme in the lungs, ACE enzyme in the lungs can convert angiotensin 1 into angiotensin 2, and we call angiotensin 2 the active form of this hormone because angiotensin 2 can have very potent and immediate effects throughout the body. For one, angiotensin 2 is a potent vasoconstrictor. So throughout your body, angiotensin 2 can stimulate vasoconstriction of arterioles to increase blood pressure. But angiotensin 2 can also stimulate the release of other hormones like aldosterone, antidiuretic hormone. And aldosterone can increase blood pressure because as a hormone released by the adrenal cortex, aldosterone acts on the kidneys to help your kidneys retain sodium. We know that sodium attracts water, so if you're retaining more sodium and not losing it in urine, then you're also going to retain more water in your body. And if you retain more water, then you also increase blood volume, which increases blood pressure. Angiotensin 2 also stimulates the release of antidiuretic hormone by the posterior pituitary gland. And what antidiuretic hormone does is prevents water loss by your kidneys, or prevents diuresis, hence the name. And so antidiuretic hormone can help you retain water and therefore increase your blood pressure. Antidiuretic hormone is also called vasopressin. And vasopressin is also a vasoconstrictor, which can increase blood pressure. And last but not least, angiotensin 2 can also act on the hypothalamus to make you feel thirsty. So when you have that sensation of thirst, that can make you seek out water. You're going to ingest water, which increases your blood volume and increases blood pressure. So just to summarize this process, what we see then is that the kidneys will release renin when blood pressure is low. Renin converts angiotensinogen into angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by the enzyme angiotensin converting enzyme, or ACE, which is found in your lungs. Angiotensin 2 can actually stimulate vasoconstriction to increase blood pressure, or it can also stimulate the release of aldosterone, which can help you retain sodium and water to increase blood volume to also increase blood pressure. What's missing on this slide are the effects of angiotensin 2 on thirst as well as antidiuretic hormone. So we can add two more limbs to this flow chart here. where angiotensin 2 makes you thirsty, which helps you seek out water, which would increase blood volume and increase blood pressure. Angiotensin 2 also stimulates the release of antidiuretic hormone, or vasopressin, which vasoconstricts and also helps you retain water in the kidneys to increase blood volume and increase blood pressure. Now, for individuals with hypertension or high blood pressure, we can give them drugs that block this enzyme, ACE, or angiotensin converting enzyme. So if their blood pressure is too high and we block ACE and put them on an ACE inhibitor, they could basically prevent the conversion of angiotensin 1 into angiotensin 2, and then you don't get these effects, which means you don't get rises in blood pressure. So putting someone on an ACE inhibitor is an effective way to reduce their blood pressure in the long term. Now, we know then that angiotensin 2 produces increases in systemic vascular resistance because angiotensin 2 is a vasoconstrictor. Now, there are other hormones that can help regulate blood pressure as well, like atrial natriuretic peptide. However, the atrial natriuretic peptides, or atriopeptins, act to decrease blood pressure. Now, hence the name, these are actually released by the atria of your heart when there's too much stretch within your heart. So when the atria have an excessive amount of stretch, which you would assume would occur with high blood pressure, the atria will release this hormone, ANP, or atrial natriuretic peptide, and these hormones basically block the reabsorption of water by the kidneys, as well as the reabsorption of sodium by the kidneys, which can allow for excessive releases or excretion of sodium and water. And when you lose additional sodium, you'll lose additional water, which reduces blood volume and therefore reduces blood pressure. It turns out that there's another hormone called endothelin-1, and it's a class of hormones called the endothelins, but this particular isoform is important in blood pressure control because it's actually a potent vasoconstrictor. So we can have drugs that block endothelin receptors to help reduce blood pressure by preventing the vasoconstriction that endothelin-1 would cause. Now, over the course of a day, there are normal fluctuations in blood pressure. For one, this is mediated by the suprachiasmatic nucleus of the hypothalamus. This is part of your body's internal clock. And that over the course of a day, this can lead to fluctuations in blood pressure. In the morning, it turns out your blood pressure is the highest, so we have this morning surge, and it starts to fall over the course of middle morning, over the course of that day, and it becomes lowest at night. So this nocturnal dip right before bedtime and during sleep, where blood pressure is the lowest. This can be important to consider if someone has, borderline hypertension, where if you're measuring their blood pressure in the morning, they could be borderline hypertensive, but at night, they could be below that borderline. And it's just important to consider the fact that blood pressure can fluctuate over the course of a day. Now, there are neural, hormonal, and external environmental factors that can also influence blood pressure. Things like lifestyle, cognitive activity, and emotional state can affect blood pressure. If someone's excited or relaxed, that could affect the blood pressure in that particular moment in time. So in order to get the most accurate reading of someone's blood pressure over the course of a day or in their lifetime, what we want to do then is take more than one reading. Their current cognitive or emotional state can influence their blood pressure, and by taking multiple readings, you get a more accurate sense of what their sort of mean pressure is over a period of time. Now, we define hypertension as high blood pressure, and it's the most common primary diagnosis in the United States. It turns out that hypertension increases the morbidity and mortality associated with heart disease, kidney disease, peripheral vascular disease, and stroke, and it's responsible for an annual worldwide death rate of about 7 million. Now, normal blood pressure should be approximately 120 systolic over 80 diastolic. And we have different ranges of pre-hypertension, stage 1 hypertension, and stage 2 hypertension. We define pre-hypertension as about a systolic pressure of between 120 and 139, and a diastolic pressure of 80 and 89. Stage 1 hypertension would be a systolic pressure between 140 and 159, and diastolic pressure of 90 and 99. And stage 2 hypertension is about 160 and above systolic or 100 and above diastolic. Now, primary hypertension is what we also call essential hypertension. It's an idiopathic disorder, so it's an unknown etiology. And it's the most common form of hypertension in the US and worldwide. It's rare prior to the age of 10, and it turns out here that the systolic blood pressure is a major risk factor for cardiovascular disease. Some of the risk factors for primary hypertension, we have the non-modifiable and modifiable risk factors. The non-modifiable risk factors are the things that you can't change, things like family history, age, ethnicity, and genetics. Otherwise, we have modifiable risk factors for primary hypertension like dietary factor, sedentary lifestyle, obesity, weight gain, metabolic syndrome, blood glucose levels, diabetes, cholesterol, alcohol, smoking. So these modifiable risk factors are the ones that are changeable or modifiable. And in this sense, you can change your diet and how you exercise. You can change your body's weight, whether you have metabolic syndrome, which can relate to diabetes and blood glucose. You can change your cholesterol, that's modifiable, as well as other sort of lifestyle factors like alcohol and smoking. And by reducing these factors, you can reduce your risk factor for hypertension. Now, in childhood and adolescence, what we find is that there are some intrauterine risk factors too. Things like maternal smoking can make someone more predisposed for hypertension. Pregnancy-induced hypertension can also give someone a higher risk for hypertension later on in life. Dietary habits, low birth rate, lower socioeconomic status of the mother, inadequate intake of calcium by the mother, as well as breastfeeding seems to reduce the risk for hypertension later on in life for that individual. Now, we can call primary hypertension the silent killer because typically you won't have any signs or symptoms until there's already some organ damage that's occurred. So the outcomes of primary hypertension could be things like end organ damage, such as renal failure, stroke, heart disease. And so we won't have any signs and symptoms of these necessarily until the damage is done to those organs. Now, damage to the arterial system can accelerate atherosclerosis and lead to cardiovascular disease. This can also increase myocardial work, which can result in heart failure. Glomerular damage results in kidney failure. Microcirculation damage can affect things like your eyes and kidneys and most organs of your body. And increased pressure in the cerebral vasculature can lead to hemorrhage, which can lead to a stroke. Now, the treatment for primary hypertension revolves around things like lifestyle modifications. It turns out that there are measurable changes in blood pressure when people change their modifiable risk factors, such as weight, sedentary lifestyle, and dietary factors. So if someone loses weight, exercises, goes on a DASH diet, which is high in fresh fruits and vegetables, limits their intake of alcohol, and limits their intake of sodium and nicotine, all of these can help to reduce blood pressure. Otherwise, there are drug therapies for hypertension as well, things that would help target systemic vascular resistance, stroke volume, and heart rate. And if you can reduce these factors, you can reduce blood pressure. So what this table shows are those modifications that individuals can take. And for each of these modifications, there are typical ranges of blood pressure you should expect to see with every sort of category. So if someone reduces their BMI by certain factors here, you can see then that their blood pressure would reduce by a predictable range. If someone goes on a diet that's high in fresh fruits and vegetables, but that's low in dairy products and fat, saturated fats, and meats, which are high in saturated fats, you can expect measurable decreases in blood pressure. We can see decreases in blood pressure due to decrease in sodium intake, because if you don't intake as much sodium, you also don't retain as much water, therefore reduce your blood volume and reduce blood pressure. If someone exercises, it can also help reduce their blood pressure post-exercise, as well as moderate intake of alcohol. So it's recommended that it should have less than two drinks a day for men, and less than 1 drink a day for women. And this can also reduce blood pressure. Now, secondary hypertension is actually attributed to a specific identifiable pathology or condition. Now, this is the most common form in infants and preschool children. It's also the most common cause for childhood secondary hypertension. Would be things like renal disease and coarctation of the aorta, which is a congenital defect of the aorta. Other causes for children could be things like obstructive sleep apnea. Now, for adult secondary hypertension, this can be related to things like renal artery stenosis, which can reduce glomerular filtration rate, which would increase blood volume and increase blood pressure. Secreting tumors of the adrenal medulla, like pheochromocytoma, can increase the catecholamines, which can increase your sympathetic response and therefore increase blood pressure. Otherwise, pregnancy, obesity, and hyperaldosteronism can also increase blood pressure. But again, remember, these are also secondary hypertension causes which are due to some other identifiable pathology which increases blood pressure. Now, we have a difference between hypertensive emergency and urgency. Hypertensive emergency occurs when there's a sudden increase in either systolic or diastolic blood pressure, where we have evidence of end organ damage. When you're starting to see signs and symptoms of damage to a particular organ like the kidneys or the retina or the liver, what we find then is that this would be called hypertensive emergency, where there's evidence of damage to that hypertension. Now, this differs from hypertensive urgency, where we have similar blood pressure elevation, but there's no evidence or signs and symptoms of end organ damage. And this is actually going to be treatable with oral medications to help bring down blood pressure. Now, low blood pressure can come about in several different ways. Things like orthostatic or postural hypotension is an extreme response to a change from supine to upright position. So if someone goes from a laying down position to standing up, and you don't see rapid enough rises in blood pressure to help with cerebral perfusion, this can lead to orthostatic hypotension, which can lead to loss of consciousness. Now, orthostatic hypotension can also be caused by excessive increases in heart rate, which can lead to dizziness, blurred vision, confusion, syncope. And unfortunately, orthostatic or postural hypertension is associated with cardiovascular disease, and it's a risk factor for stroke, cognitive impairment, and death. So it's important to note that orthostatic hypotension isn't always a benign condition. Now, orthostatic hypotension can be the result of a problem with the Vasomotor Center or baroreceptors. It could be an adverse effect of drug therapy, arterial stiffness, blood volume depletion, or secondary to other disease processes like cardiac dysrhythmias or vasovagal reactions.